Vanakkam. When we see a child with an obstetric brachial plexus palsy or birth brachial plexus palsy as it is now known, we will note that there are problems in the shoulder. In the previous video, we have seen that these problems are weakness, contracture, and joint deformity. So when we do see such patients, how do we treat them? How do we treat each of these components? How do we treat the weakness? How do we treat the internal rotation contracture? And how do we treat the joint deformity? All this is dealt with in this video. Continuing on the management of shoulder problems in birth brachial plexus palsy, we have seen in the previous video that what happens to the shoulder in such conditions are three things: weakness, contracture, and joint deformity, otherwise known as glenohumeral deformity or dysplasia. In this video, we shall be seeing the different types of management of these three problems. Firstly, is there a role for conservative management of these problems? We need to remember that conservative management, that is the use of therapy, the use of botulinum injections, and the use of appropriate splinting is useful only during the infancy phase. Once the problems have established, there is no role for conservative management, and surgical options are the only good method of management. Can we do nerve surgery now to correct these problems? After the age of 2 years, the results of nerve transfer procedures are poor. So, how do we manage these problems of the shoulder, and what are the aims of management? Since there is weakness of one group of movements or muscles acting on the shoulder, we need to restore function. Since there is a contracture of the shoulder, we need to rebalance the shoulder to promote remodeling. And since there is a joint deformity, we need to reduce the glenohumeral joint. And how do we plan to achieve all this? By following the basic principles. That is, we need to correct the weakness by restoring the external rotation power of the shoulder and, if necessary, abduction power. We need to release the contracture by releasing the tight anterior structures. And thirdly, to correct the joint deformity, we need to ensure a concentric reduction and good range of movements of the shoulder. So now we have learned that there are three problems. The question is, which should we deal with first, or can they all be managed together? Of these, it is the weakness and contracture that develop first, followed later by the joint deformity. So between the weakness and contracture, it is important to note that the contracture must be released first and then the weakness should be addressed. They can be done together also. But if only the weakness is corrected without releasing the contracture, a useful range of movements will not be possible in the child. When the joint deformity develops, it should be corrected. But we have seen that the joint deformity can occur very early, in which case the joint deformity should also be corrected along with the correction of the contracture and weakness. In some children who present very late, the joint deformity may have to be addressed first before dealing with the other problems. First, we shall consider how the contracture is managed. The indications for contracture release are limitation of passive abduction and external rotation in infants who fail to regain passive external rotation in the first 6 to 12 months of life. In children with shoulder dislocation, with or without greatly increased retroversion with low PHHA on MRI are also candidates for contracture release. We need to usually avoid formal shoulder surgery less than 1 year because post-operative therapy is difficult. The ideal age is 18 months or later. And we have already seen that correction of weakness alone with tendon transfers will not result in joint remodeling. Hence, the release of the contracture must be done either before or along with correction of the weakness. Contracture release of the shoulder can be done either by an open approach or arthroscopic approach using a 2.7 mm scope. Use of the arthroscopic approach has the advantage of less scarring and enables assessment of the whole joint. The primary structure causing anterior tightness of the shoulder is the subscapularis muscle. The other muscles like the pectoralis major, latissimus dorsi and teres major do not cause much of contracture. The secondary contractures are caused by shortening of the glenohumeral ligaments primarily and also to a certain extent the coracohumeral ligaments. There are three techniques of releasing the subscapularis. The anterior Z lengthening of the tendon, which is a distal procedure, subscapularis muscle slide, which is a proximal procedure, and a minimally invasive subscapularis release procedure. The proximal release is ideal in patients less than 4 years of age. The periarticular distal releases can be done in older children. By the technique of anterior Z-plasty or Z lengthening of the subscapularis tendon, every 1 centimeter produces 20 degrees of external rotation. Isolated subscapularis Z lengthening is effective at early follow-up, but results are not maintained at mid-term follow-up according to a study. The subscapularis slide procedure is an open procedure done from the lateral border of the scapula. It was introduced by Karolis and Brahimi. With the child in lateral decubitus position, the incision is made along the lateral border of the scapula, approaching the scapular ridge through the interval between the teres major and teres minor. The procedure consists of releasing the origin of the muscle from the surface of the scapula using a periosteal elevator. The third technique of minimally invasive subscapularis release is done from the medial border of the scapula by a 1 cm incision placed at the junction of the upper 1/3 and lower 2/3. First a hemostat and then a periosteal elevator is introduced in the submuscular and extraperiosteal space. The subscapularis slide is done in a clockwise fashion according to this paper. 3 common complications can occur after release of the contracture of the shoulder in birth brachial plexus palsy. The first is loss of internal rotation power and subsequently the development of an external rotation contracture. The second problem is limitation of activities of daily living such as zippering and buttoning in the midline that occurs consequent to the loss of internal rotation power. With time and growth in children, some loss of function has been noted after extra-articular tendon transfers and contracture release also. Having seen how the contracture of the shoulder is addressed, we shall now see how to manage the weakness that may be seen in the shoulder affected by birth brachial plexus palsy. Lepiscopo primarily reported muscle transfers for residual brachial plexus palsy patients in 1934. It was much later in 1978 when Hofer described the latissimus dorsi and teres major transfer to the rotator cuff along with the release of the pectoralis major. When we say weakness of the shoulder in birth brachial plexus palsy, we are actually referring to weakness of abduction and weakness of external rotation. So the aims of treatment of this weakness of the shoulder are improvement in the active abduction and external rotation motion and improvement in the function by aggregate Mallet and Palsy scores, that is the pediatric outcomes data collection instrument scores, and these need to be done for children who fail to attain active abduction and external rotation. The basic principle I follow for this surgery is the transfer of latissimus dorsi and teres major to the insertion of the rotator cuff on the greater tuberosity. This insertion might be modified according to the need of the patient. If there is associated internal rotation contracture, surgery includes lengthening the subscapularis and the pectoralis major muscles. We shall now see the technique of the latissimus dorsi and teres major tendon transfer. The patient is placed in lateral decubitus position. The correction of the internal rotation contracture must be done first, either with a subscapularis slide or a subscapularis lengthening, as already described earlier in this video. If the pectoralis major is also contracted, a small 2 to 3 cm anterior axillary incision is made to access the tendon of the pectoralis major, which can be lengthened. Then a posterior axillary incision is made from the edge of the latissimus dorsi anteriorly to the inferior edge of the deltoid posterior-superiorly. The latissimus dorsi and teres major muscles are identified and dissected. To maximize tendon excursion, we need to release the adherent fascia and mobilize the tendons and muscles back to their neurovascular pedicle. Now the insertions of the latissimus dorsi and teres major are isolated and released from the humerus. As soon as this is done, we place inverted non-absorbable horizontal mattress suture in the tendons to prepare for the eventual tendon insertion. Next, we dissect between the deltoid and the triceps to locate the supraspinatus and infraspinatus insertions on the greater tuberosity. After their identification, we need to ensure 4 things. First, the abduction external rotation must be more than 110 degrees, that is 20 degrees beyond vertical. The adduction external rotation must be more than 60 degrees. If the adduction external rotation is less than 30 degrees and the joint is not reduced or stable, we need to perform a joint capsulotomy, reduction, and if needed, the subscapularis lengthening even further. The scapulohumeral angle must be more than 140 degrees with the scapula stabilized. If it is not so, we need to consider musculotendinous lengthening of the triceps. We must also ensure that the humeral head is reduced and stable throughout the arc of motion. If not, we need to evaluate for potential causes like untreated contractures and treat it accordingly. The usual insertions of the latissimus dorsi and teres major are the supraspinatus if we want to achieve abduction, the infraspinatus if we want to achieve abduction and external rotation, and teres minor if we want to achieve external rotation only. The supraspinatus and infraspinatus insertions are seen over the greater tuberosity, which we have already dissected. The latissimus dorsi and teres major may be very closely adherent to each other, in which case a conjoined tendon transfer is done. If they are separated, they can be given to 2 different insertions according to what we have discussed. The suturing of the tendons to the greater tuberosity must be done with strong non-absorbable sutures in a trans-periosteal fashion, and this suturing must be done to the epiphyseal region to avoid injury to the physis. First, a trial suture is taken. The range of motion and the joint stability are tested, making sure that there is no external rotation or abduction contracture with the applied trial suture. We also need to test for scapular winging that could be caused by too tight an insertion, that is the putty sign, which we have already discussed in a previous video. Post-operative immobilization with shoulder spica in slight abduction and external rotation of more than 60 degrees. This should be maintained for 6 weeks. We use a detachable shoulder abduction splint as shown in the photograph. After 6 weeks, 2 weeks of active abduction above the splint is advised. And after a total of 8 weeks from the procedure, we can remove the abduction splint and apply an elbow straightening splint to prevent co-contraction from the biceps, and then start active passive abduction and external rotation of the shoulder. All the procedures we have seen have been described as a technique known as the Mod Quad procedure by Rahul Nath in 2007. This consists of 4 steps, that is, latissimus dorsi muscle transfer for external rotation and abduction, teres major muscle transfer for scapular stabilization, subscapularis muscle release, and axillary nerve decompression and neurolysis. The insertion of the latissimus dorsi and teres major is done to the teres minor tendon and not to their insertion near the greater tuberosity. In some situations, we find that the deltoid is not working. In those cases, we need to ascertain whether it is only a weakness or this deltoid is not able to act because of co-contractions. If co-contractions are the problem, we need to nullify the muscular imbalance as well as break the tendency of co-contractions by administering Botox to one set of the adductors and by doing a muscle transfer from adductors to the abductors. If the deltoid is weak, the Chuang's technique can be done. Here, if the pectoralis major is strong, the clavicular head of the pectoralis major is added to the anterior fibers of the deltoid to increase the power of abduction. This requires a moderately strong deltoid. Trapezius transfer of the upper third of the trapezius to the deltoid gives moderate results. Transfer of the levator scapulae can also be done for the deltoid. When we use weak donors, the initial good results do not keep up with growth and puberty-induced weight changes. Finally, we shall consider the surgical management of the glenohumeral deformity or dysplasia. There are three main procedures described: derotation osteotomy of the humerus, glenoid anteversion osteotomy, otherwise known as varus osteotomy, and shoulder arthrodesis. The procedure of derotation osteotomy of the humerus will not improve global glenohumeral motion, but the arc of shoulder rotation is reoriented into a more functional position and global shoulder function is improved. The goal of this procedure is to have the hand reach the mouth, forehead and occiput without losing the ability to reach the genitalia, abdomen, chest or contralateral hand. The procedure can be done by two approaches, the lateral approach and the medial approach. Whatever is the approach used, the first thing under anesthesia is to have a final assessment of the passive range of motion of the joint. Then the surgery is performed with the patient in a beach chair position. The proximal end of the humerus is exposed in an extended deltopectoral fashion. Subperiosteal exposure of the humerus is performed lateral to the pectoralis major insertion. Transverse osteotomy just proximal to the deltoid insertion is done. We need to secure the proximal screws of the plate first before doing the osteotomy. This controls the humerus and facilitates correction. Then the rotational correction is done. This may be anywhere from 40 degrees to 90 degrees, and it is important to protect the radial nerve during the osteotomy. Temporary fixation is done to make sure that the hand can reach the mouth, occiput, chest, abdomen and genitalia. Then definitive internal fixation is performed. Glenoid anteversion osteotomy is based on the principle that we convert the shoulder joint from one where tendon transfer and soft tissue release cannot restore the active motion to a situation where it can. The osteotomy is made 5 mm proximal to the glenoid articular surface. After restoring the position of the humeral head in relation to the glenoid surface, the osteotomy is opened out and wedge bone graft is placed inside. The third procedure that can be done in neglected shoulder problems in birth brachial plexus palsy is shoulder arthrodesis. It is a salvage procedure that is occasionally indicated in the skeletally mature patient. It is indicated in total plexus injury in which there is a painful flail shoulder with best outcome seen when the rest of the shoulder girdle muscles are functioning, that is the trapezius, levator scapulae, serratus anterior and rhomboids. Apart from these procedures described on the humerus, another procedure has been described known as the triangle tilt procedure by Rahul Nath in 2010. It is based on the finding that in the shoulder of the child affected by birth palsy, there is a deformity of the scapula also, which has been described as the SHEAR deformity or the shear deformity, which we have also talked about in the previous video. So to correct this problem, osteotomy of the clavicle is done at the junction of the middle and distal thirds with a semi-rigid fixation to prevent a non-union. Osteotomy of the acromion process is done at its junction with the spine of the scapula, and bone grafting is also done. And finally, osteectomy of the superomedial angle of the scapula is done. When all these procedures are done, the head of the humerus is allowed to come back into its position to articulate with the glenoid. In this position, splinting is done in adduction, external rotation and forearm supination. Let us now summarize what we have seen so far about the management of the shoulder in birth brachial plexus palsy. If the patient is young, that is less than 1.5 years of age, and the glenoid is not severely deformed, arthroscopic or open reduction with subscapularis lengthening is performed. If the age is more than 1.5 years, we can add a concomitant latissimus dorsi and teres major tendon transfer. In situations where the contracture develops in the first 1 to 2 years of life, supervised therapy for 3 months and MRI to assess the glenohumeral joint must be done at regular intervals. If on MRI the joint is normal, we can continue intense therapy with or without Botox injection and splinting program. If the child is not compliant for therapy, isolated scapularis lengthening with or without soft tissue release should be done. In children with mild deformity of the shoulder, which is type 2, extra-articular procedure like the anterior release of the myostatic contractures and posterior latissimus dorsi and teres major tendon transfers are enough. If the deformity is more severe, that is type 3 or 4, joint reduction, which consists of reduction of the humeral head and anterior capsule release, needs to be done in conjunction with tendon transfers. In children with reconstructible type 4 deformities, posterior opening wedge glenoid osteotomy with bone graft needs to be done. If the joint deformity is too severe at any age, advanced type 4 or type 5, humeral external rotation osteotomy is advisable. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about decision making in birth brachial plexus palsy and the surgical strategies that can be followed. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.